Hello and welcome to What's Possible Liver Transplants for Patients with Liver Cancer, brought to you in partnership with UPMC. My name is Lorraine Stiehl, and I'm the Chief Executive Officer of the American Liver Foundation and caregiver to my husband, Chris, who is a transplant recipient. Joining us today is expert Christopher Hughes, MD, Surgical Director of UPMC's Liver Transplant Program, and one of his patients, Michael Weisner, MD, a fellow physician, liver cancer survivor, and living donor liver transplant recipient. Together, American Liver Foundation and UPMC are excited to bring you this informative webinar focused on the successes and the challenges of liver transplantation in patients with liver cancer. Today, we will review the types of liver cancer, talk about which patients qualify, and why some are at a disadvantage while waiting for a deceased donor liver. Along the way, we will hear about the patient's perspective, common concerns, and available resources from Dr. Weisner. At the end of our presentation, we will host a question and answer session. So please be sure to insert your questions in the Q&A box in the chat. We'll get to as many as we can later in the program. Now, let's jump in. Take it away, Dr. Hughes.
Thanks, Lorraine. There have been a lot of advances in the treatment of all types of cancers over the last 5 years. It's been pretty dramatic in the survival rates of all types of cancers. And that has spilled over into management of patients with liver cancer and our ability to be able to transplant them. When you look at liver cancer as a whole, the subject of liver cancer, you can kind of divide the types of cancer into two main types: those that are primary cancers, meaning that they start inside the liver, and those that are secondary liver cancers, meaning they start somewhere else in the body and they travel to the liver, and now there's cancer in the liver because of that. Previously, prior to about 7 or 8 years ago, we almost never transplanted someone who had a tumor outside the liver that had now spread to the liver. And the reason was because we didn't have advanced enough treatment protocols with chemotherapy and immunotherapy to be able to treat the cancer outside the liver so that they would be cured with a liver transplant. But that's changed, and now with those advances in chemotherapy and immunotherapy particularly, we're able to transplant more people. Usually what we're talking about in transplanting patients with liver cancer is we're talking about the primary cancers, and there's two types of those. And the type that you have is dependent upon the type of cell in the liver that cancer comes from. So if you look at a picture of a liver, you see the main kind of reddish maroon part of the liver. Most of those cells are called hepatocytes. And those hepatocytes are in there to basically clean your blood, filter the blood, manufacture proteins like blood clotting proteins and proteins that build your muscle, for instance. Those are the functional cells of the liver. If you get a cancer from that type of cell, and a cancer is just when a cell starts growing out of control. So your cancer type is based on the type of cell that the cancer came from, that the original cell that started to divide out of control. If that is a hepatocyte, then you have hepatocellular carcinoma. The other type of cell in the liver, and it's not as many, there's about 6% of the liver is made of this type of cell, and that's the cells that line the bile ducts, the channels that are up in the liver that carry bile or waste products out of the liver. Those cells are called cholangiocytes. And so if you have a tumor that develops in the cholangiocyte, then you have cholangiocellular carcinoma. Most of the time when we see one of these, hepatocellular carcinoma or cholangiocarcinoma. Usually when we see one of those, it's in a person who already has underlying liver disease, some sort of process, hepatitis or autoimmune disease, primary sclerosing cholangitis, primary biliary cirrhosis, lots of different diseases that end up doing the same thing, damaging the liver over time repeatedly, and their liver tries to repair itself, and it's damaged more by that disease process, and it tries to repair itself. That process of continual damage and repair can lead to a cell inside the liver starting to grow out of control, and it becomes a tumor from whatever type of cell it is, hepatocellular carcinoma or cholangiocarcinoma. And so most of the people that we see with these types of tumors have that underlying liver disease. And so many of them aren't really amenable to having just surgery to remove the part of the liver with the tumor in it because the rest of their liver is not healthy enough to be able to undergo that kind of surgery. And then we're faced with transplant. So those types of tumors, hepatocellular carcinoma and cholangiocarcinoma, those are primary liver cancers that start out in the liver. And as long as those tumors are contained in the liver and haven't spread outside to the rest of the body, then we can potentially treat that patient with a transplant and cure them of their cancer. Now, we don't want to routinely transplant people that have tumor outside the liver. And the reason is if we transplant them and there's tumor somewhere else, and now we lower the immune system to get the body to accept the liver and not have any rejection. The rejection rates today are very low, by the way. But if we do that, then we kind of remove some of the body's own innate defenses against cancer. And that cancer could potentially grow wherever it was that we left it, whether it was in the abdomen or the lungs or whatever. So that's why we put patients through a pretty strenuous imaging process before the transplant to be as sure as we can that we're not leaving tumor cells behind. Sometimes we can't tell if we are or not because those tumor cells might just be one or two somewhere else in the body. But that's one way that we select for patients that we can transplant. Now, there are a couple of other types of tumors that start outside the liver and go to the liver that we can treat with a transplant as long as we have already removed the site that it originally came from. For example, if a person has a colon cancer and that cancer has spread to the liver, but now they've had surgery to remove the cancer in the colon so that the only place is in the liver now, that person is potentially curable with the transplant. And that's something we wouldn't have considered 10 years ago. The same is true for another type of cancer called neuroendocrine tumor. Neuroendocrine cells are cells in the body that release hormones in response to nerve stimuli, things like insulin and glucagon and adrenaline. Those type of cells can also develop into tumors somewhere else in the body and spread to the liver. But as long as we've removed the part that it started from, and now we only have tumor in the liver, that person's also a potential transplant candidate. So in Dr. Weisner's case, for instance, he was diagnosed with intrahepatic cholangiocarcinoma, meaning carcinoma from the bile duct cells up inside the liver. And he can tell you his story, but he came to us having had surgery before coming to us for transplant as an attempt to try to remove the cancer from his liver. But then there was persistent cancer in the liver, so it was clear that we were not going to be able to cure the cancer that we felt was only in his liver from all the tests that he had done. We couldn't see any tumor outside the liver, so we felt like we could potentially cure him with a liver transplant. So when we have a patient who's referred to us to be evaluated for a liver transplant, then we put them through what we call a liver transplant evaluation, which is about a 3-day process of meeting our team, different people from our team, and getting different tests done, blood tests, x-ray tests. And we evaluate that patient from the standpoint of a hepatologist, which is a medical liver doctor, a transplant surgeon, a nutritionist. If it's necessary, they may see a psychiatrist, a physical therapist, because a lot of our patients with liver disease start to lose a lot of their strength, and so they need an assessment of their physical status. And so our patients meet all of those people from our team. They get these blood tests and x-ray tests done. And at the end of all this, when we have all of their information together and all of their results together, we get our entire liver transplant team together in a big conference room. It's about 50 people that are involved in this meeting. And we put their results of this patient up on the big screen, and we talk about their case and present all of their results, go through all of the results. And at the end of that, we have a discussion about that patient to decide what we need to recommend to them. Are they a transplant candidate? Do they need a liver transplant? Do they need it now? Is there anything else we should be doing in the meantime? Because we don't have a liver right now, so it's not like we're rushing off to surgery. Do we need to do something between now and then? Is there a reason they can't be a transplant candidate? For instance, do they have underlying heart disease or something like that? Some medical reason that would make them not a candidate for a transplant. All those things get discussed by our team. And we discuss it until there's 100% agreement with everyone on our team as to what we should recommend to that patient. And we call them and say, hey, the team met, and here's what we think after all this. And if we think that that patient needs a liver transplant, then the first thing we have to do is get them registered with the United Network for Organ Sharing, UNOS. UNOS is the organization that oversees transplant for the whole country. And they have a headquarters. Their headquarters is in Richmond, Virginia. And that's where the computer system is that has the name of everyone in America who needs any kind of transplant, heart, lung, liver, kidney, whatever. For the people who need a liver transplant, they're going to rank you on the waiting list with everyone else who needs a liver transplant based on your MELD score. You may have heard them talk about the MELD score before. The MELD score stands for Model for End-Stage Liver Disease, and it basically tells us how sick a person's liver is. And so what they want to do with that is the higher your MELD, the higher you are in the waiting list, meaning the sickest people get the livers first. That might disadvantage someone who has a liver cancer, because that person is not necessarily dying of liver failure. They need a liver as soon as they can to keep the tumor from getting outside to the rest of their body before they get the transplant. So it's important for them to get transplanted. And there are some rules within UNOS that will let us move people up the waiting list. They call it MELD exception points. If you have a certain type of cancer with certain criteria, they will let you move up the waiting list to try to get higher up the waiting list to get a liver from someone who has died and donated their organs, a deceased donor. The other option is if a person has a living donor, a person who wants to donate part of their liver to them, in which case, if that person, we agree from our committee that we think that person needs a transplant and they will benefit from transplant, we put them on the waiting list, and now someone steps forward and says, I want to donate to them. Then we're going to bring their donor through for an evaluation, much like we did the patient, the recipient. It's not as many tests as they have to do. It's about a day and a half of testing. They still meet the different people from our team. They meet our donor surgeon, Dr. Humar, who does all of our donor operations, and he would talk to them about what the risks are and all of that associated with the donation. And then once we have all of that evaluation completed, we present the donor to our committee to make sure there's 100% agreement on our team that we think it's safe for them to donate. And if we approve them as a donor and we already have the recipient listed for transplant, now all we have to do is pick the day that we want to do the operation. And the two of them come into the hospital on that day, and they go into operating rooms that are right next to each other, and the operations happen simultaneously. And that's what Dr. Weisner went through and his donor went through when he was being evaluated to have a transplant for his cholangiocarcinoma. So maybe I can have Dr. Weisner share with you about that process of going through the evaluation, and maybe something about his donor as well.
Oh, thank you. Well, this process, to back up a little further, as you were alluding to, doesn't start in a vacuum. I had gallbladder disease some 20 years ago, and small volumes in my liver then did not really reveal too much. I had abnormal liver enzymes maybe 10 years after that, and the work was done that showed I had fatty liver disease. And I think at that part of our understanding of the disease in the 90s, we would have done a lot more about it now than we would have then. And I did, as a physician, did not pay that much attention to what things might have been done differently in terms of diet or prevention. And then one day when I had this odd abdominal pain down inside my rib cage and showed up in our local community hospital, and a CAT scan revealed metastatic disease through my liver, but no other source. It was a very shocking day, obviously. And that's when we got connected here to Pittsburgh for the initial work on my liver cancer. The diagnosis was made here. I had almost a full year of chemotherapy here and biologic therapy with the biological agents. And it was at the urging of the extended family that someone said, are you not a liver transplant candidate? And even as a physician, I did not feel I was necessarily a candidate. And calling the program, I asked that, could someone just check my chart for me? Everything's in the electronic record. And to my surprise, I suddenly had a nurse navigator assigned to me. And the next day, you called my cell phone in my clinic while I was working in my office, which was astounding. And we started this long journey to see if indeed I was a candidate. And we did an extensive workup, I think over 6 months or more, to see if there was any evidence of cancer outside of my liver after the 10 months of chemotherapy and biological therapy. And we did not find any at that time. And my youngest daughter, Claire, stepped forward. We have the same blood type by accident. And she was a very close match to me. And it was in her process, they asked her particularly to make sure that, we had not forced her hand in any way. It was her decision to want to donate. And one of the things that was troubling me so much in that time period is my liver was deteriorating. I was having ascites and I was having fluid build up in my abdomen and distension and this terrible umbilical hernia. As we discussed, if you get in there and find cancer and I'm not a transplant candidate, please just fix the hernia. I remember that distinctly. And when I woke up from the surgery, I had a transplant and things have gone swimmingly since then. And not to get ahead of the story, but some 9 months later, we did find a small to use a technical term, oligometastasis up in my lung, very small site of something that escaped, which was annihilated with 3 radiation treatments, and I've had no evidence of any other cancer outside my liver since then. So I've been exceedingly lucky, which is why I've gone back to practicing family medicine in my retirement years, literally. It's part of which is giving back, because I've been given a gift.
What was your daughter's experience like?
I think she went through the process very well because she was young and athletic. She had just completed being a college soccer player. And I think she adapted and recovered very quickly. Within a month, she was hiking long distances, and within a few months was back in the gym working out again, and she's in tremendous shape. And to jump way ahead in the story, we just got back from a ski trip to Utah, and she can ski her father very well.
And she was in the hospital about 5 or 6 days.
Both of us about 5 days.
You were out pretty quickly as well.
We were out within the week. We anticipated I would be in for 2 weeks, and we were out in the week. So, yeah, the surgery went very well.
Going back to what you said about early on when you had been treated for your cancer for a while, and then the question was, can you have a transplant or not? You know, one of the things that we do in evaluating a patient here at UPMC, any person who comes to us who may have liver cancer, we have a tumor board made up of hepatologists, hepatobiliary surgeons who operate on the liver but don't do transplants, oncologists, medical oncologists, radiation oncologists, pathologists to show pathology slides if there's a biopsy or something like that. It's a multidisciplinary group that basically reviews the imaging and biopsies of a person and then decides, what do we need to do next? Do they need a transplant? Do they need a resection? Do they need radiation? Are they not a transplant candidate? All of those things get discussed. And that's how we funnel patients with liver cancers to do to do whatever type of treatment they need. And we put you through that process. We had discussed you at our tumor board process before deciding about transplant. But I'm interested to see if there's any questions online that anyone wants to ask.
Yes, thank you, Dr. Hughes and Dr. Weisner. That was such an insightful conversation. And Dr. Weisner, you have an incredible story. Thank you for sharing and bringing the patient perspective to our discussion today. I'd like to now open it up for some Q&A. And I see in the chat, we already have a few questions. Okay, let's get started. So Dr. Hughes, what is the success rate or the rate of cancer recurrence in other areas of the body?
Actually, because we put patients through such a rigorous analysis beforehand, the recurrence rates are actually very low, especially for hepatocellular carcinoma. What Dr. Weisner had, cholangiocarcinoma, is one of the most aggressive types of cancer there is. And the fact that he was even able to have that area of tumor outside the liver show up after his transplant, and now that's gone, and he's been cancer-free for more than 2 years, I think, since that happened, just speaks to the advances that have been made in cancer treatment overall. So mostly what we see in transplanting patients is hepatocellular carcinoma. That recurrence rate is less than 20%, which is quite dramatic after transplant.
Okay, thank you. Another question for you, I see, Dr. Hughes. Is it possible for my hepatitis B or liver cancer to come back after transplant?
It is possible. If hepatitis B is a disease which is a viral disease, and that virus gets incorporated into the genome, the genes of the person who has it. And so that virus is always present after you have it and has the potential to return. Now, the treatments for that are excellent now. And so we rarely see hepatitis B get out of control or be a problem after transplant, but we do treat people basically consistently for the rest of their life on a medication, a by-mouth medication to prevent that hepatitis B from coming back. Now, hepatitis C is different. Hepatitis C is a disease that doesn't get incorporated into the genetics of the person, and so it can actually be cured so that it won't come back. And the medications today have cure rates higher than 99.9%, literally, that's the statistic, of curing people from hepatitis C. We will even, if we have a donor, even a deceased donor that has hepatitis C, sometimes they can be a donor to a person who does not have it, meaning we give them a transplant just so we can give them a liver, but now we've given them hepatitis C, but we treat the hepatitis C after the transplant. And so these types of diseases, these recurrent diseases, are very much treatable and preventable after the transplant. The hepatocellular carcinoma could come back, which means that it had basically been in another place in the body and now it's come back into the liver. It's rare for them to de novo, meaning just out of the blue show up in the liver. That's a rare thing. And so that's pretty rare.
Thank you so much, Dr. Hughes. Dr. Weisner, again, your presentation was so powerful and in terms of your story. What advice would you give to someone just starting to consider a liver transplant for liver cancer?
One has to be very honest about assessing what your odds are, what your chances are, and be very accepting of what outcomes might come your way. We had a lot of family discussion, marital discussion about, is this the right thing to do? Should I choose not to put myself at risk of a surgery? Should I put my daughter at risk of a surgery? Should I just quietly go my way with the chemotherapy and hope for the best for a couple more years? Or do I want, as is my nature, and I always warn my own patients about this every time I give them advice. They say, "Doctor, what should I do?" And I say, "Don't ask me. I'm a fix-it person. Be careful, you know?" So I'm giving everyone my advice from the fact that I don't like to leave things undone. I'm going to tear into it and fix it. But that's my choice for my life. I'm saying, let's fix this thing and see what we can get out of it. And that's how I approached my decision for my life. But this was a chance, which has worked out well for me, to get completely away from this cancer and get a lease on life that otherwise I wouldn't have. Now, I respect, as Dr. Hughes would say, this is cholangiocarcinoma. This is one of the world's most aggressive cancers. And I've done, my own as a professional about other cases. There's one in the literature that came back 8 years later in a kidney someplace, But if this disease ever comes back on me, I will be very chagrined, but I will not be surprised because that's the nature of the cancer.
So sorry to hear that about your particular kind of cancer.
But that's the reality. You have to be
Yeah.
able to deal with the reality of what you're
Yeah.
in when you're going to make this kind of literally a life and death kind of decision.
Yeah. I mentioned earlier that my husband had a transplant for an autoimmune disease. I lost my father-in-law he was very young, and he died of liver cancer. Sadly, 30 years ago, he didn't have an option for transplant. And, it's great that we see so many options, and again with living donation. And that's a real priority for the American Liver Foundation to really talk about this amazing gift of life with living donation as well. Dr. Hughes, when is it appropriate to be referred for liver transplant?
As soon as you know you have significant liver disease, I think it's worthwhile to get connected to a transplant center.
Yes.
Because you have medical and surgical teams that, even if we think it might be early to consider you for transplant, meaning you've just been diagnosed with cirrhosis and maybe your MELD score is very low, you're doing well. Many people can live a long time with cirrhosis and don't need a transplant yet. But at least that gets you on the radar. We know who you are. We know what's going on with you, because the thing about cirrhosis is, things can make the liver decompensate, suddenly get worse. Because when a liver is working at 100% and doing its job, it doesn't have any disease in it, and it's working at 100%, it can way overdo its job. It has a lot of redundancies built in. So as you start to get sicker over the years, and you may not even know that you have a liver disease, but over time, that 100% function goes to 90%, to 80%, to 70%, and you may not even know it. And your doctor may check your blood work, and the blood work doesn't show that there's any problem either. And so when you're in that situation where you've been diagnosed with your liver disease, your liver function is coming down. You might be getting to the threshold point where the liver does start to suddenly have problems. You need a certain amount of function to survive. And now you've lost some of that function. And now any little incremental change in your liver function may suddenly show up as high ammonia levels affecting your brain. Veins in the esophagus, which could break and bleed and have a GI bleed. Fluid in the abdomen, which may may get infected and cause the liver to decompensate and suddenly get worse. And you don't want to have a liver that's suddenly getting worse, and the transplant team has no idea who you are, because now we have to start fresh and find out what's going on with you, evaluate you quickly, and kind of do a transplant sort of emergently. What we want to do is, as soon as we think you need a transplant and the risk of going through the transplant itself, the operation, is outweighed by the benefits of getting the transplant, that's when we want to do it. We don't want to do the transplant when you're so sick that it makes it hard to get through it. And that's really the main benefit of living donor liver transplant, is because we can transplant people before they lose all their muscle mass. We call that sarcopenia, before they lose all their muscle mass and get encephalopathic and admitted to the hospital with high ammonias, and they're having ascites fluid drained every week and starting to get renal failure, kidney failure from all the fluid problems that they have, swelling in the legs, all of those things which are signs of end-stage liver disease. If we can get you transplanted before we have to deal with a lot of those, that's the real benefit of living donor liver transplant. We can transplant you before you're so sick. And that leads to people getting out of the hospital in even 5 or 6 days, which is pretty remarkable after that kind of an operation.
As a general physician, I would also add, you want to get connected to the surgical team early, because the rest of your body might also undergo degeneration in the years that you're waiting for this transplant. You want to make sure your heart doesn't go bad, your lungs aren't going bad. You want to still be a good surgical candidate when your time does come up to have the liver transplant.
Real good point. Absolutely. Well, I'm very excited to share. We have a couple of more questions that have been posed through the Q&A. So here's one for Dr. Hughes. I am a liver cancer patient and I want a second opinion on whether or not I need a liver transplant. Where can I go?
Well, theoretically, you can go to any transplant center that you want to be evaluated. Here at UPMC, you just have to call us, um, and we can actually possibly do a second opinion without even you having come here. We can look at X-rays, we can get your records, and evaluate that. We do that. I do that almost every day, evaluating people who want to come here to see if they're a potential candidate or not. So if you want a second opinion, I would say get it. I think it's a good idea for transplant patients a lot of times to do that anyway. I think it's a good idea to be seen also at a transplant center that does living donor liver transplants, because most transplant centers do not. They don't even offer that to you. So I think it's a good idea to get educated and to make sure that you're being seen. You don't want to be lost in the crowd, and you don't want to be at a center that is not giving you the utmost of attention.
Yep. Very good points. And, patients need to be their own advocate and their caregivers need to be an advocate, right?
Right.
And if you don't hear from a center for a period of time, follow up. You all are very, very busy in the transplant community. And, patients need to be vocal and ask where they are in the process. So thank you for that. Dr. Weisner, what advice would you give someone looking to become a living donor?
That is a very good question. One of the things I know is important for being a living donor is you have to be in fairly good shape yourself. Correct me if I'm wrong. If one has a fatty liver yourself, it's not a good time to be donating because your liver may not grow back so well after you've donated. So that's a concern.
Yeah.
Free from disease, obviously. That might seem odd, but you mentioned transplanting diseases with hepatitis in them, but you wouldn't want to do that electively.
Yeah, and in the living donors, we have to, this is a healthy person going through an operation. And so for us, we have an age limit of, they have to be between the ages of 18 and 60, 18 because they need to be able to consent for the operation. And 60 because we know that above the age of 60, there are more complications of any type of surgery for someone. And we want them to be in general good health. For instance, if they're overweight, though, for instance, we usually have a body mass index cutoff of 30. But if somebody is above that, we've had patients lose weight so that they could donate. And so I think if you want to be a donor, or there's a possibility that you could be a donor, just register with us. It's very easy to go on upmc.com and register as a donor and let us figure out if you can be one or not. And if you have, for instance, say his daughter had not had the same blood type or a compatible blood type with him, we might have another patient with a donor and they're in the same situation, but maybe Dr. Weisner's donor would fit that recipient and their donor would fit him, and we can swap the donors, a paired exchange. And now we've got two people transplanted who otherwise neither one would have been. So if you think that you want to be a donor, register with us and let us see if it's possible.
Such good advice, and we are so appreciative of those living donor candidates. They truly are angels, and, even thinking about giving this amazing gift of life. So thank you. Dr. Hughes, we have another question in the chat. My father is 65 and living with liver cancer. At his age, is he eligible for transplant, either living or deceased?
Yeah, in fact, the decade of 60 to 70 is probably the highest incidence of liver disease and liver cancer where we transplant patients. Most of our patients are in their 60s. We've transplanted, as were as you were. We've transplanted patients into their 70s. We transplanted a very robust 78-year-old, and she did beautifully. A lot of it is making sure they're in the best shape that they can be to start with. And so much of it, as you alluded to earlier, so much of it is mental. It's attitude of getting through the operation. I'm going to do this. I can make it. We don't want to see people give up their hope before getting their transplant. And sometimes that happens when people have chronic diseases. And so I want to be encouraging to them that, if we can maintain your strength and maintain a good attitude, then you can get through it. And we do it at even well up into the 70s.
I think I was 64, did mine. Yes. Okay.
You were 64, is that what you said?
Yes.
Okay.
Yes.
Oh, good to know.
Now he's 28.
Yes. At least my liver.
That's right.
So good to know. Good to know all of this. I think sometimes people feel they are too old, and it's good. Okay, another question from the chat for Dr. Hughes. What lifestyle changes should I make after a liver transplant to ensure the best possible outcome for my recovery and long-term health?
So that's a great question. You have a new lease on life. So many of our patients come to us having had chronic liver disease for a long time. They've lost their strength. They've lost their muscles. That sarcopenia we talked about earlier. Their day has eroded into trying to get up from the bed and maybe making it to the couch, and probably taking naps in the afternoon because you're tired and everything that you do is exhausting, to getting a liver transplant. And when you get the liver, from the time it's put in, it'll start working triple time to get all of that reversed. The ammonia will be cleared and down to normal by the next day. The liver will work triple time to try to build the proteins that have been lost from your muscle mass. But you have to be able to feed the liver those signals that I'm getting out of bed. That's where the mental part comes back again. I'm going to do this. I'm going to get out of bed. I'm going to start walking. I'm going to change my lifestyle. Good nutrition and exercise. And you don't have to be Jack LaLanne, if you're old enough to remember Jack LaLanne. You don't have to be like that, but at least getting up and around and getting back to your life. I mean, the whole purpose of doing this is getting back to a normal lifestyle and going out and doing things yourself. People say, well, can I go to the mall and can I go to a movie theater? Yes, you can. And you don't have to wear a mask and all that kind of stuff. Get out and get back to your life, or get back to work, like Dr. Weisner did.
And a year and a half after my transplant, I had a bilateral knee replacement. Last year I went skiing. You can do that too.
Well, and Dr. Weisner, maybe you can share some of the nutritional tips for patients pre and post transplant that work for you, and maybe you can speak up a little bit more. Sometimes we have a little bit of difficulty hearing you.
Very well. The advice, particularly in my own instance, where the fatty liver disease precedes and follows the liver transplant, is probably to be more vegetarian as you can stand from your prior habits and culture and beliefs. I don't drink any sweetened beverages anymore. My coffee is black. I drink plain water. I drink unsweetened soft drinks if there's soft drinks. Trying to maintain a healthier weight is key. I'm back in a sedentary job again, which is not the best lifestyle, but being active, as I would advise all my patients anyhow, every day. The food plate that's 1/2 vegetables, 1/4 starches, 1/4 meat proteins is the same advice I would give all my patients. The cardiac diet, what I would tell all my heart patients, is probably what we should all be eating. And to get away from concentrated sweets, get away from high-fat meals. The new liver will do fantastic things in that first year after you're transplanted. My cholesterol has gone to zip. My A1C's dropped to 5.3%. You could do anything with a brand new liver, goes right in, but that's not going to last forever. You know, life will take over. You have to take care of yourself.
All good advice for actually everyone, but of course, liver patients as well. It's great to hear. It was such a big change in your overall health. That's terrific. Okay, well, the questions just keep coming to us. So, Dr. Hughes, here's a question. I recently had an ultrasound that revealed a cyst on my liver. My doctor said it was nothing to worry about, but my grandfather died from liver cancer at 62. I'm concerned. What else should I do?
Liver cysts are very common. I might have one. I don't know. I haven't had a CAT scan, but liver cysts are very common, especially individual or just a few cysts in the liver are very commonly seen incidentally in people getting CAT scans for other things. And so I think that's not something that's really something that person should be worried about. There is a possibility for cysts to become cancer. It's very rare. I think if you have some imaging follow-up, usually what's recommended is to follow up in 6 months or a year to have that imaged again to make sure the cyst isn't growing or changing. But I wouldn't be concerned if I were that person. Now, there are some diseases of the liver like polycystic liver disease, which is a totally different thing, which leads to basically overgrowth of massive cysts. And that's basically an inherited disease. So I think that's a separate issue. But a person with a single liver cyst, I wouldn't be concerned about it.
Okay, good to know. Well, I'm learning a lot through this presentation. I'm sure hoping that our audience as well. I'm sure they are. Okay, Dr. Weisner, how long did it take you for you and your daughter to recover, and how did the recoveries differ?
My daughter recovered much faster. I would say in about 4 to 6 weeks, she was probably back to normal activity. It took me more in the order of 3 months to get back to more what I would consider normal. That first month was pretty trying in terms of getting back to activity. I can remember just making up the stairs to the second floor of the house to go to bed was a very big challenge in the first month after that transplant. One of the things the program likes us to stay within an hour or two of Pittsburgh after that transplant. We happen to have a home an hour and 20 minutes away. And it's our second home here in Somerset County. And making that second floor to the farmhouse was a challenge for a long time. I didn't have to sleep on the couch downstairs anymore. But building back strength is something you have to work on. And building up stamina, I would say, is the biggest thing that had to come back. Because particularly after a year of chemotherapy, There was times I needed a hand to get up off of soft furniture. It was very debilitating, some of the chemotherapy I had. So that, in addition to the transplant, were things you had to get over to get back to health.
Yeah. So, Dr. Weisner, since we're talking about you and your daughter, I'm curious about your daughter, and
Yes.
Here's a question in the chat. It says, "How did your daughter become your living donor, and what emotions did you feel?" You sort of alluded to it earlier, but maybe to answer this question, you can share more.
It is part of the selection process here at UPMC that they do a separate evaluation for the donor. And there is a psychological evaluation to make sure this is being done at her wishes,
Yeah.
not my wishes, not my spouse's wishes. It was her desire to do so. And it was. I can tell you, Claire wanted this so badly, she went out and bought an over-the-counter blood test kit. So we actually tested, found out we were both A positive blood. You know, it was her idea. It was something that I don't think either of my daughters were ready to see their father pass away at 65. You know, it was.
Did you hear after that? Here's a question I have for you.
Yes.
After the transplant, and maybe even before, did you hear about the stress that your family that weren't going through either operation had with both a daughter and a husband going into the operating room? That's probably a tough day, a long day.
I heard a little about that. There's a spouse off camera here who would allude to that, but yeah.
And what did she say about her day waiting?
Nothing I'm going to say in the air.
It's a difficult day for the family, knowing that both people are in the operating room. And so that's why during the operation, we're calling out to say, everything's going fine, just to reassure them, because we understand that that's tough. And as soon as operation's over, we come out and talk about how it went. But sometimes it's harder on the family who's not asleep than it is on the ones who are asleep,
Yes.
at least for that day, I should say.
Yes.
Yeah. I too can weigh in on that. I remember my husband in one room and my stepson in another room, and being rolled out of surgery, and oh my gosh, that was quite the day. So I sure understand your family, Dr. Weisner, and your wife and others. Okay, since we're on this topic, Dr. Hughes, a question in chat says, "I would like to begin the process of becoming a liver donor to see if I'm a match for my mother. Where and how do I start the process?" You alluded to it earlier, but maybe you can really give more specifics on how they can reach out to UPMC.
Yeah, so if a person, we prefer them to register on the website. So on upmc.com/transplant, they'll see a place that says, I want to be a donor, and they can register to be a donor. And basically they're just giving their contact information. And every morning our living donor coordinators look at the registers, the registrations that have happened overnight or the day before, and start contacting those people regarding potentially donating. So we have nurses whose job it is to make the contact with the donor and get that process started, to explain the whole process, what's involved, and what early sort of screening testing we need. So they'll ask them questions regarding their overall health and their medical history. And then we'll start with just blood typing to make sure that things, people are compatible and things. And then if we feel like we should do a full evaluation of that donor, then that's scheduled for them. And they come in for about a day and a half and meet our team and get some testing done. And then we have our meeting to decide if we think it's safe for them to donate, and we make a decision about whether they can be a donor or not. Our donor acceptance rate, meaning of the people who register to be a donor, almost 70% are accepted as donors. That's a pretty high acceptance rate for donors. So if we can figure out a way for them to be a donor and help their loved one, or maybe even a stranger, then we'll figure out how to get it done. In fact, it's interesting is just since I sort of brought that up, about 10% of our donors don't know the recipient. They're altruistic. They contact our center and register as a donor, knowing that there are people who need liver transplants and they just want to donate. We've even had people who have donated a kidney in the past who now want to donate part of their liver. We've had that multiple times. And so it restores your faith in the world to see what people can do when it comes to somebody else needing a helping hand.
Thank you for sharing all that. And again, this is a huge priority for us at the American Liver Foundation, and we're doing all we can to identify non-directed, altruistic living donors. I have two questions left in the chat, and one, Dr. Hughes, you sort of handled it on the donor side of things, but maybe you can handle it, tackle it on the patient, the recipient side. The question is, how can the transplant team help me with decision making if I feel overwhelmed by the process?
So I'll say this from the donor standpoint, and then I'll address the recipient standpoint. From the donor standpoint, when the donor comes through for their evaluation, they're going to meet a person that we call the living donor advocate, the independent living donor advocate, the ILDA. And that person's job, they have no skin in the game as far as this transplant goes. They are there to talk to the donor to make sure that they are comfortable with the donation, that there's no coercion. And by coercion, I don't mean somebody is really pressuring you to transplant, but that person might feel that. And an example might be, I'm the youngest person in my family and the healthiest, and I'm feeling the pressure from my family like I should be the one to donate. Those kind of things get talked through to make sure that we don't feel like that person is pressured in that way. On the other side, regarding the transplant recipient, that's on us to give them the best information that we can. And so we put them through the evaluation, not only to learn about their liver, but everything else about their health as well. And that's why we take this to our committee, because this is a big decision. It's not a decision for the recipient to make on their own. It's not even a decision for a doctor to make on their own. It's a committee decision where we get everyone's opinion together to say, what's the right thing to do in this case? And so a lot of the evaluation of people coming through for their evaluation as a recipient is educating them about what's going on in their body. People hear liver disease and then they come in for an evaluation and then they really have no idea why they're experiencing the problems that they're experiencing, and not really understanding, I was healthy 2 months ago and now I feel terrible. This came on all of a sudden. Well, no, it didn't really. It's been going on for years, and now you're just getting to that point where you're starting to decompensate a bit, and now you're feeling the symptoms, and your liver is actually sicker than you think it is. A lot of that is on us to educate them about what's going on with their body so that they understand. And usually when people understand what's going on, it's a lot easier to make the decision of, yeah, this is what I need to do. Let's go for it.
Well, that's really helpful information, and I'm glad you referenced both the donor and the recipient. It's good to know you have these independent living donor advocates for those interested in donating part of their liver. That's good to know. Okay, last question for Dr. Weisner, the patient and physician. 2 years post-transplant, how are you feeling? How has life changed, improved for you?
Life is back to normal in the sense that I don't think of myself as being ill. I probably should take more time with this gift and try to separate work and life and get to a better balance, honestly said. I've
Okay.
been thankful. I go for regular checkups with a whole host of physicians. I see Dr. Hughes and his team at least once a year now. Saw my kidney specialist 2 weeks ago. Saw my sleep apnea doctor last week. Saw my regular physician about 4 times a year for my blood pressure. I've been amazed as someone who works in this field how good my lab results look now that I have a new liver in my body. The analogy I jokingly say is like dropping a crate motor in your jalopy to make a hot rod out of it. This liver will work way better than a 68-year-old liver should work in terms of controlling my sugar and my cholesterol. But it leads me to pause as to how the rest of my life is going to go, Yep. No,
Well,
and
isn't
that's the
it?
question I can't answer.
Yeah. Well, it's wonderful to hear about your team of medical professionals. And of course, you have a supportive, community, I'm sure, of family and friends. And we are just so delighted to have met you and Dr. Hughes. And thank you for sharing today. We hope that we have helped so many people. So we've reached the end of our time together. Everyone who registered will receive a follow-up a follow-up email with a recording of this program and a list of resources and support services outlined throughout the presentation. And if you have any questions about the University of Pittsburgh Medical Center, UPMC, please visit their website at www.upmc.com/transplant. And if you have more questions about liver disease, American Liver Foundation is here to help. Call our free helpline at 1-800-GO-LIVER or visit liverfoundation.org to view our robust library of educational resources and support services for patients and caregivers, including our Living Donor Liver Transplant Center, a National Transplant Center finder, and free monthly virtual support groups moderated by a licensed clinical social worker. You can also change the face of liver disease research by registering for our new American Liver Foundation patient registry, the first ever patient registry for all types of liver disease, created to help provide researchers with a better understanding of liver diseases, the impact of current treatments, and how liver disease affects patients. Please learn more at patientregistry.liverfoundation.org. Thank you once again for joining us today.